sessions on care of normal newborn, newborn resuscitation, neonatal procedures, and neonatal X-rays. And today also we are looking for a very exciting session by Dr. Sanjay Wazir. But before that, I request Dr. Alok Bhandari, IEP Delhi President, to say a few words on this course. Dr. Bhandari, sir, please.
Good morning, sir, and thanks, Pankaj, but I'll exceed my brief today, not about the course. I'll speak about what is hot in NICUs in this hot season. Everybody must be aware that last week we had a unfortunate incident where fire erupted in a NICU in Vivek Vihar, East Delhi. So my humble request to all to please go through the fire drills. Just sensitize your people, take care of all fire-related precautions. Even if fire NOC is not possible because of some stringent norms, but at least the basic services, whatever facilities we can have to combat fire, must be there. We must train our staff to have a basic drill about the usage of fire safety equipment. Use of inflammable material should be reduced. Try to use fire retardant materials which are available now. And the escape route from the nursery should be very clear. And please also sensitize your staff, like what is alleged in this last week's incident, that staff members, none of them got injured or burnt, but our innocent 6 children and newborns lost their lives. So that's a sad moment. If each staff could have picked 1 or 2 babies, and the entire lot could have been saved. 6 children got trapped and asphyxiated in a chamber. So that was definitely preventable if our nursery staff would have been more vigilant. So that is what I'll say, and rest back to academics. I think everybody knows and recognizes all over the country that Dr. Pankaj is doing a great job by moderating this and conceiving this NEO course, which is a good brushing up of knowledge about basic neonatal basics in neonatology. And for office practitioners, I'm getting a very good feedback that people are really happy, and this 1 hour spent on Sunday morning is always well spent. That is what everybody says. So please have a happy learning session. And Sanjay Wazir and Madam, please take over, please.
Thank you, Dr. Bhandari. And I think this is a high time that we at administrative level also start doing some fire-related training of doctors, and then doctors can move forward and do it for the NICUs and nurses also. At our hospital also, we did a drill yesterday in which all the residents and nurses and staff were trained. And I'm sure Delhi IP can lend a helping hand in that aspect also, which we are going to definitely put forward to the Delhi IP and Central IP also. So now coming back to today's session is on neonatal encephalopathy, and we have chairperson Dr. Neelam Player. Dr. Neelam Player is Padam Bhushan, and I think in my knowledge, she's the only Padam Bhushan neonatologist of the country. She has been the chairperson of Department of Neonatology, Sir Gangaram Hospital, and right now she is senior consultant and advisor to the Department of Neonatology, Sir Gangaram Hospital. And I have been following this dream of neonatology under her guidance for last 25 years plus. So I look forward to a very exciting session under the chairmanship of Dr. Neelam Clare. And Dr. Sanjay Wazir is the speaker. So I request Dr. Neelam Clare to say a few words about neonatal encephalopathy and Dr. Sanjay Wazir. Over to Dr. Neelam, please.
Thank you so much, Dr. Pankaj. And I must congratulate Dr. Alok, Dr. Pankaj, and other office bearers of IIP to take up this continuing medical education on neonatology in a capsular form. And that too on the Sunday morning when your mind is fresh and you are relatively free. So the absorption is probably the best. It's an excellent program, and it's my pleasant duty to introduce Dr. Sanjay Wazir, who's also a very good friend. Sanjay and me come from PGI, and so he is my alma mater mate also. He's been in Delhi now for, I think, over 20 years, around that time. And he's been, the neonatologist in some of the prime hospitals. And he has a quality that, he starts a NICU, he makes it, the state-of-the-art NICU, and he moves on to another new hospital to establish. So, which is like wonderful, which is really wonderful. Apart from his academic accolades as academic body, office bearers, he's a staunch academician, and he has written a lot of books on science of neonatology, as well as, parent guides also. And today he'll be speaking on a very important subject, which is neonatal encephalopathy. As you know, that neonatal encephalopathy is almost used as a synonym for hypoxic ischemic encephalopathy, though as per strict definition, neonatal encephalopathy is more of a syndrome with neurological dysfunction. And a lot of other conditions also, like infection, genetic conditions, metabolic conditions, which can lead to this neurological dysfunction syndrome, also are clubbed under it. But, as you know, that, 2/3 of cases of neonatal encephalopathy in developing countries are more or less due to hypoxic ischemic encephalopathy anytime during the intrapartum or peripartum period. And diagnosis is tricky. A lot of, imaging, a lot of blood tests, a lot of markers have come over the years to not only diagnose, but also to sort of prognosticate encephalopathy. So it's a tricky subject. And I'm sure he's also going to touch upon therapeutic hypothermia, which again is a little bit of controversy in the developing countries because of some recent publications. So with all that complications and all those controversies to be resolved, I hand over the mic and the pedestal to Sanjay. Over to you, Sanjay.
So thank you so much, Dr. Claire. And before Dr. Sanjay takes over, just one announcement that you can post your questions in question and answer session. And at the end of the talk, we'll be taking all the questions, and be assured we are going to answer each one of you. Thank you so much, and over to Dr. Sanjay.
Thank you, ma'am, and thank you, Pankaj. Good morning, everyone. It's an honor to be present on a digital platform gathering organized by Delhi NNF, and I'm profoundly grateful for the opportunity to share insights on a topic which is not only critical but also deeply close to my heart. That's neonatal encephalopathy, and largely because when I was doing my DM, at that time this was my thesis as well. So which means that this helped me pass the exam as well. So I would also like to extend my heartfelt thanks to esteemed moderator Dr. Neelam Claire for her exceptional leadership and dedication to advancing neonatal care. We all acknowledge and recognize her contributions to the field that have been nothing short of inspiring, and it's a privilege to have her guidance on today's session. Now, in terms of neonatal encephalopathy, is a condition that continues to pose significant challenges in neonatal care world. And let me share a brief experience that underscores the importance of our work. I vividly remember a term infant who was born after a complicated delivery. The parents were distraught. And of course, we always label somebody as who's crying, not crying as a child. And with quick intervention, including Dr. Neelam Claire mentioned about therapeutic hypothermia and continuous monitoring, our team worked tirelessly to stabilize the condition. And over the next couple of days and weeks, the Ria's condition improved, and today she's a healthy, active child. We did not get a permission to post her photograph, so that's why I'm not posting it here. But with that in mind, let's embark on a journey together. We'll explore what is the etiology, examine the latest diagnostic and therapeutic advancements, and discuss the role of multidisciplinary care in improving outcomes. And thank you once again, Dr. Claire and Dr. Pankaj. Can I share my screen now?
Yes, please.
Sanjay.
Okay, so like when we say neonatal encephalopathy, the word itself means like somebody who has a disturbed neurological function in the first, and when it applies to neonates, so a disturbed neurological function, whether it is a consciousness which is impaired or it's repeated seizures or a combination of this in the first couple of days, applied to babies who are more than 35 weeks and above, because preterm population tends to be a little different, so we not get into that, but largely any disturbed function, any change of sensorium is classified as encephalopathy. And as madam said that we have a very high incidence in the developing part of the country, in the world, whereas in the developed part of the world we say probably the incidence is somewhere around 1 in 3 per thousand, but in the developed part, in the developing part, I said it is around 6 to 8 per live birth, and that is attributable to so many factors, including a lack of a good prenatal care, a lack of good facilities for delivery, and of course the lack of skill about neonatal resuscitation, which thankfully the NNF is doing a great job by making sure that people are learning that skill fast. Now, when we talk about etiology, like, when I was not married at that time, I used to blame the obstetrician. I would never look at the chart and say all defects are related to or problems related to the obstetrician. But after I get married, and for my own sanity and for the knowledge that I acquired over a period of time, I realized that obstetrician is not responsible for most. And when we talk about encephalopathy, most of the times it is the factors which are related to genetics or preconceptional risk factors, maternal risk factor, so much so that the placenta I never used to examine when I was doing my residency, but at that time I realized placenta can give you so much of information about why this particular child had kind of a encephalopathy. And over a period of time I realized that encephalopathy, as I said, HIE, in the Western world, half the cases of encephalopathy are related to hypoxic ischemic encephalopathy. And when we say hypoxic ischemic encephalopathy, the important point here is ischemia. So oxygen ki kami or lack of blood, blood to the brain is responsible for a distinct neurological outcome and neurological pathology compared to someone who has only, other causes. And simply hypoxia as such, अगर आपका blood pressure maintain है, blood supply ठीक है, so it is not likely to cause, and we all know children who have congenital heart disease probably would have less likelihood of they are at a saturation of 60, 70, 80% and may not be like encephalopathic in the way HIE tends to be. So India mein infections tends to be a very large cause, unlike in the Western world. So sepsis, whether it is early onset sepsis with meningitis, or sometimes it is meningoencephalitis because of certain viruses like enterovirus, herpes. These are other causes where some children may have encephalopathy. And metabolic disorders may, like we have transient metabolic disorders like hypoglycemia, or even things like inborn errors of metabolism, transient endocrinopathies. So these are some of the other reasons why child may be encephalopathic without having an ischemia. Acute asymptomatic seizures because of any reason for that matter can lead to encephalopathy, usually brief, but if it is prolonged associated with other anomalies, sometimes it may be the start of neonatal onset epilepsies or genetic encephalopathies. And sometimes it is just that an undiagnosed congenital malformation is responsible for the encephalopathy, and that is different. Now in clinical conundrum, when we see diagnostics, so it's available at most of the tertiary levels, but when we are dealing with a child in a tertiary or secondary level testing, we have to make sure that we make a rough estimate. And reason is important because, like, if it's an HIE, we need to start therapeutic hypothermia within 6 hours. But if it is something else, for example, if it is neonatal sepsis, for example, using hypothermia in that scenario may be a little more dangerous. Like if it is hypoglycemia, just treating a hypoglycemia may resolve encephalopathy without having to resort to any other, and it also helps us to uh, prognosticate the cases. So we need to divide the babies on clinical features, like अगर first day में किसी को encephalopathy है, so then most likely he has a perinatal asphyxia or an intracranial hemorrhage. Choriamnitis can present with cerebral depression right at birth, and those with congenital malformations would tend to present, those severe kind of congenital malformation, lissencephaly or anything, would present with seizure and encephalopathy on day 1. If the child was well on first day, so one of the clinical takeaways is that if the child was feeding well on the first day or second day on breastfeeding, and third day he became encephalopathic, rule out HI without doing any investigation, because बच्चा जो है अगर पहले दिन और दूसरे दिन, because maximum risk of encephalopathy or the damage happens in HI on day 1 between 12 to 24 hours. If the progression did not happen for the first 48 hours, you're probably dealing with some other etiology. And most common among them are, of course, in Indian scenario, in neonatal sepsis. Hypoglycemia can present in an Indian scenario at any point. Neonatal stroke again can present anytime between the first 7 days, and metabolic disorders like inborn errors of metabolism would present with encephalopathy in many cases, like urea cycle defect or organic acidemias or other metabolic disorders. They usually present after a time of feeding, and if it is more than 5 days, then it is either a late onset sepsis or genetic epilepsy syndromes, or sometimes like herpes or varicella or other kind of leukoencephalitis. Now, clinical history consciousness, because as I said, most of the information has to be based on the clinical examination. So in HI, you need to see history में एक perinatal complications का history होगा, which is in the form of like whether it is in the form of a sentinel event, a cord prolapse, or a sudden abruption, or like vasa previa. There's something which has happened acutely, and the child's the mother's CTG was going fine, and now the CTG has suddenly dropped. So there will be some history like this, and the child may be altered right from the birth, or sometimes the child may be normal at birth, and then gradually over the next course of 12 to 24 hours you find that the child's sensorium has become normal. So just because the child cried at birth does not mean that the child does not have an HI. So I mean, we're not going into details of acute and chronic HI, but generally the children would present from irritability in HI1 to coma in HI3. So again, the muscle tone could vary from hypotonia to hypotonia. There are abnormal primitive reflexes, but seizures, if they happen, usually would happen in the first 24 hours when the maximum brain damage is happening. So very early onset portends a bad prognosis, but अगर 24 घंटे के बाद हो रहा है and this child had been sensorium wise normal in the first 24-48 hours, then you think of other causes. And one of the important aspects of HI is that it's a multi-organ dysfunction, because it involves ischemia. So the other organs like kidney, the heart, the lungs, and things would get also impacted. And that is why it is important for you to be looking at a presence of dysfunction in other organs, look at metabolic acidosis, and of course we go to the MRI and EEG in some time. On a clinical front, metabolic disorders would present with, इनकी हिस्ट्री थोड़ा सा डिफरेंट होगा कि बच्चे जब तक फीड नहीं किया तब तक ठीक थे, फीड करने के 24-48 घंटे तक भी ठीक थे, और उसके बाद they gradually went into encephalopathy. So it lethargy आई. So there is not an acute event that from 0 to 100 it went. It's relatively uncommon for metabolic disorders, although some of the hypoglycemia may be present like this. But when we talk of inborn errors of metabolism, there is a progressive lethargy which sets in, and the reflexes and other things, as I said, would be normal, but seizures generally present a little later after the onset of lethargy. So that may be slightly different from HI. And then of course, like we know, there are certain specific things for inborn errors of metabolism, जैसे maple syrup urine disease का एक characteristic odor होगा, Now, for example, biotin deficiency, there is a characteristic rash, so these are some of the things that you probably may have to look at and determine what are the kind of tests that we need to do for this. Infections, we would have to keep a high, consideration for infections in Indian scenario, especially if there are maternal infections, false smiling like maternal fever, prolonged rupture of membranes. These are some of the risk factors and sometimes in Indian scenario when the babies come from outside, तो हमारे लिए ये differentiate करना मुश्किल होता है कि whether HI is the primary event or is the coexisting infections also, but अगर सिर्फ infection की वजह से है, so they generally present with lethargy and irritability first, and the sensorium is not that bad as compared to sorry.
ठीक है इसमें
You can go ahead.
हाँ नहीं, अभी तो यही है, वो जो DGHS की एडवाइजरी है उसी को उसको
Can I go ahead?
Sanjay, you can continue. I think if somebody is not muted his,
okay,
you can continue.
Sure, ma'am. Thank you.
लग सकता है
on the other hand, when it's like, and there are other signs like fever, temperature instability, or bulging fontanelle, these may be signs that suggest that probably infection is the cause here, and unlikely that intracranial hemorrhage, on the other hand, like usually associated with prematurity, but sometimes term babies can have intracranial hemorrhage, especially like those with the passive
अलार्म जो होता है.
Kindly mute your microphone because it's causing little disturbance.
गाइडलाइन में देख लो ना, DGHS वाली जो दो उसमें.
I think it's Pankaj. Somebody needs to call Pankaj for this.
Okay, I'll do that. You continue.
So intracranial hemorrhage on the other hand, इसमें क्या है कि seizures होते हैं, bulging fontanelle may be one of the factors that you may require clinical examination, and especially अगर posterior fossa bleed है, so then there is a chance that there is an increased head circumference, and congenital malformations अगर हैं तो या तो family so they may have like abnormal reflexes, they may have, but their sensorium may be relatively preserved because they are born with a uniform sensorium. Seizures become more refractory and intractable. So in that scenario, these are some of the clinical pictures, even if you do not have an access to information on other things, can help you differentiate whether the child has what kind of a problem. Now, as I said, the signs and symptoms of neonatal encephalopathy that you would see is seizures, low Apgar scores, poor reflexes, and muscle tone. And generally, if you see like there is a consciousness which you see on the lower end, these are Brazelton scale. So generally, the child goes through a deep sleep, light sleep, drowsy, alert, and crying. And this is state to state variability, which suggests that your brain is functioning fine. But अगर बच्चा एक ही स्टेट में रहेगा, like for example he is crying and incessantly crying, there is something wrong with the CNS. If the child is like into deep sleep and not getting better, at all, that's like, so basically look for on a clinical examination a state to state variability. अगर वो नहीं है तो there is something wrong. And in addition, you probably would need to look at some of the basic things ki hypotonia. Most of the children would present with hypotonia, but of course, as I said, like some of them may have a hypotonia as well as a part of their disease, and especially HI1 would have a hypotonia. But उसको पता करने के लिए अगर बच्चा वेंटिलेटेड नहीं है तो you can just like use a ventral suspension or a ventral suspension or a vertical suspension or even pull to sit to see. अगर बच्चे की tone बहुत floppy है, so like a rag dog it will fall. So if you see on the left side, on the right side, this is a child who is probably pulled to sit, the head lag is so obvious. In the ventral suspension, it is more like curved body. So if you have that kind of a tone, this is slightly abnormal for a child which you see on the extreme light. So normally the scarf sign, which is movement of the elbow across the sternum, is not possible in a term baby. So if you're easily able to pull without moving the shoulder or a scapula on that side, that means the child is profoundly hypotonic. And one of the easiest thing that one could do is to look at the suck. So you wash your hand and put a glove finger into in the mouth. If the child is sucking, then you can be safely sure that this child does not have much of a pathology when it comes to encephalopathy. If the child is not sucking, despite stimulation, rooting, sucking reflex are absent, that's something which is probably not right. And nowadays we have modified Sarnat scale. Without going into detail, it's available on the net for people to use a more objective way to classify the encephalopathy, and that is something that we need to use if we are using. Now, coming to a clinical approach, when it comes to encephalopathy, it is important that we need to look at some of the common things. So we need to look at a cord blood if it is possible, look at a placenta to look for any vascular lesion, inflammation or thrombosis, ABG, CBC, and basic workup for liver, LFT and RFT coagulation profile is something that we must do for all children with encephalopathy. And we may look at neuroimaging, and we'll talk about it, and EEG. But if you're suspecting infections, we probably need to look at the blood culture, urine analysis, and CSF studies and culture. And it's my experience, although it is mentioned that unless there is a very clear-cut history that the mother in out from just before the delivery, there has been a cord abruption or a very acute sentinel event where okay, this is the cause of HIE. Most in Indian scenario, it's difficult to differentiate between infections and HIE, or is case most of the times we end up doing a workup for sepsis and including a CSF if there is a doubt. Vascular, like if there is a hemorrhage in the head, and especially the posterior fossa bleed, you probably would need to do a daily circumference to look at how it is progressing. And of course the coagulation. Metabolic, after 2 or 3 days, if you can look at a genetic urine analysis for urine organic acid and blood if the child has been feeding, to take a sample at least if you're not planning to send, but at least take a sample, because after that the child would be NPO or nil per oral, and you will lose that opportunity to actually ensure that you find anything problematic, even if the child had an IEM. And of course, nowadays there are specific targeted neonatal epilepsy genes. If you think that is a refractory epilepsy, we would probably need to look at that and look at a whole genome exome if nothing is working. Now, EEG is something which is like, we all understand that any child who has a disturbed neurological function, and EEG is something that we must do. But we are all scared, and most of the time, despite I see most units having technologically advanced equipment, EEG उनकी यूनिट में थोड़ा सा रेफरेंस नहीं होता, because a continuous or a video EEG is something which needs an expertise from a neurological neurologist sometimes, and most of the times in fact, and also needs special training to put the electrodes and to interpret that. So generally, like, people would refrain, but instead of 12 montages, at least 8 montages होना चाहिए. And for those children who or units who do not have a facility for a continuous EEG, video EEG, at least a continuous EEG is the next in line. अगर वो भी ना हो तो एटलीस्ट एक एम्पलीट्यूड इंटीग्रेटेड EEG होना चाहिए, जिसमें एक या दो वो लगते हैं इलेक्ट्रोड्स, एंड देन दे मेजर ऑन द in an abbreviated form. The word itself, it's a self augmented EEG, so abbreviated form. तो इन दोनों में है कि ये एक फुल मैच है जो 8 लीड या 12 लीड EEG है, और ये एम्पलीट्यूड इंटीग्रेटेड EEG जो है वो एक हाईलाइट्स है. So it's a compressed into some time. So the difference is that, like, the amplitude integrated, because it is highlights, because it's a large amount of information compressed into a smaller time frame, it is likely to miss some of the things. So the sensitivity of amplitude integrated EEG is not as great as the conventional and continuous EEG. So जब भी टाइम मिले आपको ये amplitude integrated में आपने कर भी लिया है, so you should probably like do an EEG. So when should you do it? You should do it any child who is at risk of a neonatal encephalopathy or is having a neonatal encephalopathy, and कम से कम 24 घंटे के लिए आपको एक continuous EEG करना चाहिए for you to know whether what is happening inside the brain. And I'll tell you why it is important, because हमें अभी तक लगता था कि हम seizures identify कर पाते हैं, but like that has been proven wrong. And सो ईजी में जनरली क्या होता है कि अगर हमारा नॉर्मल ईजी होता है पैटर्न, सो वी नो के ओके दिस इज अ चाइल्ड हु प्रॉब्ली हैज़ एन ईजी बैकग्राउंड, लाइक लुक्स लाइक ओल्ड दिल्ली में किसी खंबे पे बहुत सारे तारे लाइक नज़र आ रही हैं. So generally, like, you know, it is difficult for one to understand, but it is important to understand that most of the babies who are on EEG, so we need to see a normal EEG pattern at 6, 12, and 24 hours is predictive of a favorable outcome at 2 years of age. So ऐसे में prognosticate करना थोड़ा सा easy हो जाता है. And even if it is abnormal, like for example, we would probably see a child who's having a recovery of background within 24 hours is associated with improved outcome. नाउ एबनॉर्मल बैकग्राउंड कैसे पता लगेगा कि अगर आपकी कुछ इलेक्ट्रिकल एक्टिविटी हो बीच में बिल्कुल थोड़ा सा नॉर्मल बिल्कुल एक फ्लैट सा ईजी होगा. सो दैट इज समथिंग, of course you would need interpretation by a neurologist, but an abnormal background with sustained buzz suppression, for example, at 72 hours is predictive of death or severe disability in almost 90%. एंड अगर आपको वो भी नहीं देखना तो एटलीस्ट ये देख लीजिए. अगर ये जो है दिस इज नो ब्रेनर, लाइक अ वेरी फ्लैट काइंड ऑफ ईजी, आइसोइलेक्ट्रिक ईजी, और लाइक इंटरमिटेंटली कहीं कहीं पे स्पार्क्स आ रहे हैं एंड बाकी सप्रेशन है. सो दिस इज लाइक ए सिवियर काइंड ऑफ ए बर्स्ट सप्रेशन पैटर्न. एंड अगर ऐसा EG है in a child with HI, that's a child who has a very bad prognosis. Maybe ऐसे बच्चे को hypothermia करने से भी कोई बहुत ज़्यादा फायदा नहीं होगा. And if it is like refractory seizures with this kind of a background in a child who does not have an HI, then you probably think of genetic epilepsy syndromes. So just a baseline that we need to understand. Now न्यूरोइमेजिंग में अल्ट्रासाउंड हम जब कराते हैं कई बार तो हमें रेडियोलॉजिस्ट बता देते हैं कि देयर इज अ सेरेब्रल एडीमा. The cerebral edema is something which we see is likely to happen because there is injury. So there is no brainer that it will have a cerebral edema, and we should completely disregard that kind of a finding. The whole idea of doing an ultrasound, otherwise now with the other imaging this has become more like defunct, is to find out if there is a cerebral malformation. So you just ask your radiologist to say कि इसमें malformation है, because then it's a different cause of a neonatal encephalopathy, or there is a hemorrhage, then it is like a different cause of a neonatal encephalopathy. But expecting him to tell whether it is HI is very difficult, because it depends on the expertise on the resolution and also the extent of injury. So ultrasound is not for diagnosis, but to rule out congenital malformation and hemorrhage. We did, like as a part of a study, to look at a Doppler in the prediction of outcome. At that time I was very gaga about this, but now over a period of time I've realized there are better ways to find out the adverse outcomes in asphyxiated. So transcranial Dopplers जो suggest भी करते हैं, probably I would not advocate anymore because the utility is very limited. Now MRI is something that we know, and it's a whole lecture in itself, so I will not get into the sequences itself. There are T1, T2 diffusion weighted images, but जो HI में जो चीज़ देखने वाली है वो है ये, like so there are like HI or hypoxic ischemic encephalopathy would cause damage to a highly metabolically active regions, which includes or which are myelinated, like जो anterior limb of interior capsule, this is not myelinated at 37 weeks, but posterior limb is. So you see the picture at the down. So this is a preterm baby and this is a term baby on the right side, the down arrow. So the preterm you cannot see. So the posterior limb gets myelinated at 37 weeks. So if there is an injury in this area, as you see in this particular picture, then then you probably think that agar putamen, globus pallidum, and some cases some thalamus is grossly involved, then it is probably pointing towards HIE. So just remember, like basal ganglia and posterior limb of internal capsule. Just ask the radiologist for these two things if you have a confusion, so without getting into too much of a detail. But अगर आप ये MRI पिक्चर देखोगे, so ये देखोगे इसका डिस्ट्रीब्यूशन बेसल गैंग्लिया और थैलमस और पोस्टीरियर लिम्ब में इतना नहीं है जितना पोस्टीरियर साइड में है. दिस इज ऑब्वियसली हाइपोग्लाइसेमिक इंजरी. ये सेरिबेलम बहुत ज़्यादा इन्वॉल्व है कंपेयर टू द ब्रेन स्टेम, and of course like there are others. So cerebellum itna involvement, this was MSUD, and this was pericovirus, or because there was an extensive white matter injury as much as like extending from anterior frontal lobe to the parietal lobe, and very little injury. So if there is lack of injury in the perineum, in the basal ganglia, thalamus and other things, it is less likely that we're dealing with HIE, and we must look at other causes of neonatal encephalopathy. So coming to the management, I'm going to talk about management in the secondary level settings rather than in the tertiary level settings. So first thing that we need to understand that all plants in your garden do not require the same kind of water. So it is not because the child is encephalopathic, the child is not conscious, that we need to give oxygen as a prasad and give, because it has been seen that in an HIE scenario where the child did not cry and now has started to breathe normally, giving excess oxygen or severe hypoxia increases the risk of poor neurodevelopment by 3.8 times, which means that we need to ensure that we have to get oxygen hood out of our NICUs, because either the child requires like a nasal support for breathing, or the child needs nothing, like just giving random CO2. Of course, that is something, if you're ventilating, you make sure that the CO2 is in the normal range for maintaining a cerebral perfusion in the normal range. But what is more important is to look at hypoglycemia, because of course when the babies are born, they're born with the stress, like especially the HIE babies. In that scenarios, people forget to check the blood sugar, and if you have hypoglycemia along with an HIE, there is almost 18-fold increased risk of poor neurodevelopmental outcome. Marked hypoglycemia also worsens cerebral lactic acidosis and provokes hemorrhage. So it's important to monitor blood sugar frequently and maintain somewhere between 75 to 100 milligram. And again, I'm pertaining more to the management of HIE in this scenario, because other causes would have a slightly different management. But this is something which, as Dr. Neelam said, 2/3 of the cases are HIE. So that's why I'm dwelling on this, and very basic that you can do it in your own settings. Then again, one will have seen that the odds of death or disability increase 4-fold for every 1 degree increase in temperature of the skin or the esophageal. So make sure that the child who is, even if you're not doing hypothermia, you are preventing hyperthermia both during resuscitation, transport and inside the NICU. तो बच्चे को रैप करना या ओवर करना, that will, even if you've done nothing, temperature increased to 39 degree, you have increased the risk of damage without knowing that that has caused so much of a problem. Most of the babies do not get transferred to the tertiary levels, especially if there is mild to moderate encephalopathy. So one must remember that like fluid balance has to be achieved. पहली जो बुक्स होती थी, तो दे वुड से कि ऑल चिल्ड्रन शुड बी ऑन 2/3 मेंटेनेंस बिकॉज देयर इज अ रिस्क ऑफ लाइक SID and CCF. बट द प्रॉब्लम इज, अगर आपका फ्लूइड बैलेंस कम हो जाएगा तो यू आर ऑल्सो लाइकली टू हैव an increased risk of having cerebral perfusion which is lower. So there was one study which was done from, very pilot study done from Jipman, and unfortunately there's not much to give you an information on that. And they found out that like अगर आप बहुत ज़्यादा अगर आप restrict करते हो 2/3, your chances of transient hypoglycemia increases significantly. So now the consensus is that you start with the normal maintenance and restrict fluid only अगर SIDH है या CCF है. Otherwise you maintain and monitor the baby and the electrolytes and the fluid input output chart and make corrections accordingly. One of the other things that I see the babies, कि बच्चे को asphyxia होता है, तो all of them would end up with dopamine. Now, routine use of dopamine is not recommended, and in fact, if you need to use any inotrope, which you need to based on echo, or if not possible, at least monitoring the circulation with the CFT, with the blood pressure, urine output, and then take a call on dobutamine, because most children with asphyxia would have cardiogenic element of shock rather than some of them may have neurogenic, especially if their injury has been very severe, but predominantly if you have to blindly do, rather than dopamine, it has to be dobutamine. So what brings us to an important concept called seizures, both in asphyxia and other ways also, because Dr. Pankaj wanted me to cover it a little in detail, because we do not have a separate session on neonatal seizures. Now, अभी तक हम सिर्फ देखते थे कि अगर बच्चे को झटके आ रहे हैं, बच्चे को lip smacking है, it's like, and that was what we was told as a DM resident when I was doing 20 years back, कि any child who probably has like any kind of this motor movements would be classified as seizure, because we did not have any kind of ways to find it out. But we also then realized that if this electric activity arose in the primary motor cortex, would you have motor manifestation? But agar electrical activity happen in a non-motor area, then in that case you will not have any motor movements, and that's a very basic thing to understand. And eventually people understood, and they looked at seizure detection, and almost you're likely to miss 50% or more of seizures if you are like, some people peg it at 80% also, different studies, but 50 to 80% is the number if you look at only clinical seizures. And sometimes like certain motor automatism, say for example there is a limbic system which is charging, so you have lip smacking movements which we used to classify as seizures earlier, or subtle seizures, may not have like any electroclinical correlate. Also, when you use phenobarbital for treatment of seizures, there is something called a electroclinical uncoupling, which means that क्लिनिकल सीजर था उसको फॉर एग्जांपल, तो उस टाइम पे उसके फिनोबार्बिटोन देने से क्लिनिकल सीजर तो बंद हो गया, क्लिनिकल एक्टिविटी बंद होगी, बट इलेक्ट्रोग्राफिक सीजर फिर भी चल रहा था. तो हमें लगता है कि सब ठीक है, बट देन इट इज़ स्टिल हैपनिंग इनसाइड द ब्रेन. सो इसलिए इम्पोर्टेंट है कि जहाँ पे भी चांस हो, एंड आजकल लाइक वी यूटिलाइज लाइक ए फैसिलिटी ऑफ people, there are many neurologists who send their EEG machine, although that's not as great, but for putting on, and वो उसको लगा के रख देते थे, and they keep interpreting whenever they get a chance. So we monitor those babies for seizures unless and of course you have an augmented EEG given the limitation we just discussed. So is this time for us to move from clinical to electrographic seizures? The answer is yes. And as I said, we need to look at कि seizures को हमें treat कैसे करना है. तो generally जो होता है, when we look at seizures with a clinical suspicion, always make sure that monitor करने के लिए we have a video EEG, if not a continuous EEG without a video, if not then at least an amplitude integrated EEG. Now, this will rule out most of the non-seizure episodes, and then you will not be over-treating. But seizures with an EEG correlate, those have electrographic seizures, both in the setting of HIE and a non-HIE that you need to treat, and those of course which have an electroclinical seizure, जिसमें motor movements भी हैं, electrical activity भी है, would also need to be treated. But as I said, 50% are only electrographic seizures. And अब जब आपने treat भी कर लिया, फिर भी आपका EEG चलता रहेगा, because uncoupling की वजह से some of the clinical movements would stop, but you will probably have like a child who is not which is still showing an electrical activity. Now, treatment-wise, we need to look at, phenobarbital is the first-line drug. I'm not going to confuse you too much with, other things, but there has been a trial which suggests that phenobarbital has almost like 70 to 80% kind of efficacy against treatment of seizures compared to levetiracetam. So the first line always golden standard is phenobarbital. Now if it is a non HI setting, one may choose to use phenobarbital the second dose, although personally I feel, and I generally do not use phenobarbital the second dose 20 mg per kg. At best we'll use 10 mg per kg because there is a hepatic and a renal dysfunction in HI, and encephalopathy there is always a confusion whether it is a drug overdose or a phenobarbital effect, or because of the increased disease progression. So if not, some people use phenytoin, some people use levetiracetam. Preference for us is levetiracetam. And then lidocaine versus midazolam, again third line treatment. You can take a call based on your unit preference, and that is something which will determine. But we have understood that subclinical seizures in the last couple of years, those children who had subclinical seizures, sorry. So subclinical seizures, they had they are also needed to be treated because of the fact that if there was not treated, their seizure burden was higher, and seizure burden at 18 months was associated with worse neurodevelopmental outcome. So it is important that we need to prevent further damage by looking at all these things. But once the damage has already happened in HIE, now what is the treatment which is available is hypothermia. And hypothermia, unfortunately, is the only proven neuroprotective strategy. Rest all those things are more to do with the clinical bias and clinical judgment wisdom. But proving, if you say what is the proven therapy, cooling the brain, it is like आपको चोट लग जाती है, you खेलते खेलते तो you apply your ice, you reduce the blood supply to that area, you reduce the metabolism in that area, and the progression and the swelling becomes lesser. So it is largely that kind of a concept, that you need to cool the brain. Now when it comes to cooling the brain, the criteria have to be defined, because we need to understand that mild encephalopathy, although some parts of the world they are doing mild encephalopathy cooling as well, but abhi jo hai, for largely you need to understand which babies to refer. If the child had a significant pH of less than 7 and a base deficit -16 on cord or arterial blast, which was done within 1 hour of life, an ABGA score which was less than 5 at 10 minutes, and a history of acute perinatal events, maybe placenta abruption, cord collapse, with evidence of moderate to severe encephalopathy. Those are the babies that one must send for the closest unit who has a facility for therapeutic hypothermia. Now, if you say I do not send, then it becomes a medical legal problem on your side. Patient not going is completely within the right, but you not offering is like denial of a treatment. So you should probably get in touch, and if the patient wants to go, please send him across to the nearest center which has a therapeutic hypothermia available. But just because you do not have a facility, you do not offer, becomes denial of treatment. Now, whenever we have like a treatment, then need to understand when you're counseling a patient कि होगा क्या, उसमें the cooling would start like and nobody does a head cooling anymore now. I'll just come. But first cooling से temperature जो उसका 37 पे है, we'll bring it down somewhere close to 33.5, and within half an hour or so, and maintain that temperature for next 72 hours. And then start rewarming over the next 12 hours to make sure that the child comes back to normal. And with that, when the injury was maximum, as I said, 12, 24, 48 hours, at that time the metabolism was slow, there are various other mechanisms, but उस टाइम पे इंजरी, जब हमारा टेम्परेचर कम था, तो विद द इंजरी बिकेम लेसर, एंड दैट इज वन ऑफ द वेज दैट यू नीड टू treat. And most of the places nowadays like use the whole body cooling, and head cooling is no longer available in most places, like except for some earlier units in US. And in India, we had a privilege to work with Mira Cradle, like a company which made a low indigenous device with Dr. Niranjan Thomas in Vellore, and we tested a unit which was very cheap and almost 1/10 the cost of the whole body cooling machines. And nowadays, because the patent has gone, so now the Indian companies are making it also the servo controlled or the machine controlled hypothermia machines, which are much cheaper than this, but a phase changing material was used for cooling the babies to improve the outcome. So these are some of the devices which are available, and even if you want to install that in your NICU, it is no longer considered a very costly affair. But what is important to understand that आपको विद इन 6 आवर्स शुरू करना है. 6 आवर्स के बाद इम्पोर्टेंस उसकी हाइपोथर्मिया की इतनी बेनिफिट नहीं रहती है, एंड जितना जल्दी स्टार्ट किया जाए, सो इफ़ यू स्टार्ट विद इन 3 आवर्स यू प्रॉब्ली गोइंग टू गेट more benefit compared to the babies like who are between 3 to 6 hours, but certainly before 6 hours. And other than that, like there are some units in the West who had started doing, and I'm reminded of 1 or 2 units in the India which have started doing hypothermia, which tried hypothermia. I don't know the outcomes, but they've tried hypothermia on transport also. सो लाइक एटलीस्ट अगर हम कुछ भी नहीं कर रहे तो मेक श्योर कि गर्मी के महीने में इतनी गर्म एम्बुलेंस ना हो कि उसका टेम्परेचर बढ़ जाए. सो वी वांट टू फाइंड इट लाइक मेक श्योर दैट द टेम्परेचर ऑफ द बेबी इज not cool, but certainly not warmed, because that will reduce the efficacy of that treatment even if you're getting it done. So the last bit I'll come to, like जो होता है कि ये तो neonatal encephalopathy होगी, but वो discharge होके आएगा तो pediatrician के पास ही. Now when we are dealing with this thing, we need to see what are the things that we are supposed to do and a follow up as pediatrician to encephalopathy. Some of them may go back to the units which they are treating, but when we are dealing with children who are the first visit, which generally happens within 1 or 2 weeks of post discharge, you need to look at vital signs, growth parameters, neurological examinations, and then spontaneous movement. But make sure that you are probably looking at feeding and nutrition. I'll come to know कि हम routine में क्या देखते हैं. But 3 months, 6 months, 12 months follow up is important, because like at 6 months you need to also assess that hearing and vision have been screened both by an ophthalmologist, and sometimes the extended BERA and the VP screening to rule out a cortical blindness. You probably would need to look at some of the developmental skills. If not, you can seek the help of a developmental pediatrician to do some checks to find out whether that child has or is doing good, bad, or needs some additional help. And it is also important that 1 year is not enough. These babies would need to be looking at an annual visits, at least for things which are beyond the routine care, which includes the neurological examination, developmental and behavioral assessment, because many of the children may have behavioral issues, may have ADHD, autism, and so a developmental monitoring needs to be continued even in a pediatric OPD. And we may need to adjust the plans and coordinate with schools, early intervention programs, special ads, education. So these are some of the things that you probably would need to look at. Now, say for example, as I said, okay, there is so a baby who comes at 2 weeks or 1 month of age to do. So what are the things that you probably would need to do? A growth concern to see if the child is not growing well, or the growth or the weight is not growing, then probably there is a feeding which needs to be taken care of. Maybe we need like additional supplementation. Maybe we need like a calorie augmentation, because if the baby has a postnatal malnutrition associated with the neonatal encephalopathy because of whatever cause, then your outcome is going to be even worse. Malnutrition adds to the neurological insult which happened. Muscle tone, maybe we need to start a physiotherapy, and it is important that we need to look at those needs and get in touch with a center which probably has facilities for physical therapy, early intervention therapies, and say occupational therapies. Those who have a seizure activity which present may need a referral to a pediatric neurologist, And then, of course, apart from that, routine immunization care for such babies is something which needs to go. Now, in the OPD, when you are, before you send them to, for example, to a special scenarios or special centers for doing this thing, something that you need to do is like a general advice for starting at around 1 month of age, that you need to do work with sensory stimulation. So you can do probably an infant massage using different textures, because one single hand is not, it increases the proprioception and sensory stimulus to the child, and using a soft brush or a hand, or maybe a cloth with a different texture, or a towel which has like a little fine and gentle brushes, a skin to skin contact. For visual stimulation at this age, probably you have black and white patterns like which are available, and as cards and flashcards which can be seen, and of course face to face time. Auditory stimulation in form of a soft music, or including the parental voice, is something that you can suggest for improving the neck control. A supervised tummy time is something which we recommend and should be done as a part of a recommendation from a pediatrician. And getting a toy so that the child, or placing it in the hand where the child tries to put the thing into the hand. And a cognitive, social and interactive play using a facial mimicking is something. Those are the things that you probably can just suggest to the parents to get on with this. So in conclusion, I would conclude that neonatal encephalopathy is something which is probably a commonly occurring event in our NICUs and our kind of scenarios. And the understanding the journey of understanding and addressing neonatal encephalopathy is both challenging and inspiring. The story of Ria, which I just mentioned at the beginning, and the countless other infants remind us that why we strive for excellence in neonatal care. Advancements in diagnostic, therapeutic interventions, and multidisciplinary approaches have significantly improved our outcomes. And if you see, neonatal encephalopathy, to summarize, I would say one, NE and HIE are two distinct entities. So HIE, some of the babies may be completely normal, so there is not interchangeable. So all NE is not, and vice versa. And a systemic approach to history and a physical examination, along with the prompt evaluation of encephalopathy onset, when did it happen, when, like day of life, which you just mentioned, and the history would help us determine what is the most likely cause, and इससे हमें इसको hypothermia के लिए भेजना है कि नहीं भेजना. And seizure consideration, which means that clinical seizures are no longer considered as significant indicators in neonatal care, and you may need to look at other methods to look at whether it is video EEG, augmented EEG. And therapeutic intervention, as of now, hypothermia stands out as the sole established therapy for HIE, but it is not relevant for other causes of NE. But all that secondary manipulations that we talked about, blood sugar monitoring, oxygen and other things, is something that we have to look at in detail. And it is important that in follow-up, as a pediatrician, we need to have a structured follow-up plan and a treatment which is aimed at rehabilitation of that child. So remember, what we do in NICU is 50% of the work. What is done after discharge from the NICU into the OPD is another 50% towards neuro rehabilitation. So if you do not provide sensory stimulation and occupational therapy, a physiotherapy to a child, then all that effort which went into like the NICU goes down the drain. And with that, I will conclude my presentation, and with an urge and an appeal to go to Amazon and buy this book. And this looks like a sales pitch, but at the same time, it is no harm asking your brother and sister and colleagues for reviewing what you have done. Thank you, ma'am, and I leave it to you for further consideration.
Thank you so much, Dr. Sanjay, for taking up such a huge topic. It's a huge topic, actually. There are many topics in one topic.
Correct.
And finishing it in time. And just before we take up the questions, because there are plenty of questions in the question answer box also, which we'll take one by one. Just to re-emphasize that neonatal encephalopathy is a syndrome, though HI is the commonest cause, but as we know that infections, genetic causes, metabolic causes also remain at the bottom of the causes. Dr. Sanjay has very well, shown the spectrum, which you can take up on clinical examination, because that's the most important thing. So you may or may not have sentinel signs, which would alert you. And, HI may present early, but, you have sometimes multiple etiology that you may have HI with sepsis infection. So you may have dual etiology. So, whenever you are dealing with a baby with encephalopathy, always rule out sepsis, because they can mimic each other or they may be coexisting. Number two, sometimes genetic causes like, a floppy baby may have asphyxia also at birth. So may have a combined etiology. So that's very important. When you're monitoring clinically, imaging plays a very important role. And if you have bedside EEG in form of amplitude EEG, which is compressed EEG, it plays a great role. But if you can do a long strip, that is 24-hour EEG, will give you a lot of information. And let me tell you that, we talk a lot about electrical seizures. But in clinical practice, when you have a baby who's in stage 2 or stage 3 HIE, adding too many anticonvulsants, also with multiple organ failure, sometime, may be risky, because many of these babies have decreased urine output, they have impaired renal functions, and if you're giving high doses of anticonvulsants, sometimes, their phenobarb levels may be in the toxic levels. So, if you have a baby with multiple organ failure, always do the blood levels of phenobarb if you have facilities, and you can always get it done from a lab outside, outsourced lab, to see that the phenobarb levels are within normal limits. Thirdly, if you don't have bedside EEG, at least at the time of discharge, you must do an EEG, and if possible, a long strip, because that will also help you with the prognostication and also would help you with, what anticonvulsants you're going to send the baby with. Imaging, many a times you order the imaging very early, which is also not good, because imaging, especially MRI, should be done after 24 hours, 24 to 96 hours. And some of the late changes may appear after 7 days. So when you're prognosticating based on the imaging, you should always make sure, because, this is one of the very important issue for medico-legal problems. You should always tell that, imaging may appear normal in the first, or may appear near normal in the first 24 to 96 hours, but some of the changes, the neurological damage, may appear more so after 7 days. Another very important thing that, if the baby is not on multiple inotropes, make sure that the baby is being fed through the nasogastric tube. So feeding may be started early. Dr. Sanjay has very well covered the follow-up, which is the most important thing, because, and also the early stimulation, which should be started in the NICU very well. So I think the topic is almost very comprehensively and completely covered. And Dr. Pankaj, if you allow me, can we take the questions one by one?
Yeah. Sure, definitely, ma'am. Definitely. That's the
Right.
time to take up the questions now.
Right. So the first question is, what can be done in case of intracranial bleed, surgery or conservative?
So, most of the times, ma'am, the surgery for an intracranial bleed is generally out of context, either people do not get it or we don't have the requisite amount of the expertise. So in my own experience, I have done it only once, like, and that too for a severe extradural hemorrhage with a bad outcome. But like, people suggest that for a posterior fossa bleed, sometimes because it is going to impinge on your respiratory and other act, you may need to do a posterior fossa bleed. But for most others, which is mild to moderate hemorrhages with no significant mass effect or clinical deterioration, you would probably choose a conservative management, especially in the newborns.
Yeah. So, cerebral hemorrhage, which is parenchymal hemorrhage, anyway, you are not going to do any surgery.
Yeah.
Intraventricular hemorrhage, ventricular hemorrhages are usually less common in term babies. But if you have a massive bleed and you develop post-hemorrhagic hydrocephalus, which is very, very rare, then probably there would be some indication. But otherwise, subdural hematomas, again, large subdural hematoma, I think are very uncommon in newborns. I mean, at least I have never resorted for any form of bleed to surgery in term babies. But if there's anybody else who wants to comment, can comment, and we can take the next question, Dr. Sanjay.
Yes,
the next question is how to confirm torch infection, IgM or IgG of mother and baby.
So like, for most of the times, like IgG may be a prevalence of like a pre-existing mother, and because of the transplacental transfer of IgG, this may just present like a maternal, even immunity, not even infection. So some other times it may be difficult. So there are other tests. So as a torch, as a clinical thing, so first thing that we need to see whether there are symptoms associated with that or not, like for example a cytomegalovirus. Then in that case, IgG IgM is probably not diagnosed. You need to do a urine PCR for looking at a copies of whether it is detected or not. And of course then there are others, like for example you're looking at a herpes infection, encephalitis, then you need to do a CSF PCR to look at herpes in the CSF. The blood value may not be of any consequence because you're looking at encephalitis. And of course, say for we know torch infections, syphilis for example, we need to look at whether the mother's like the VDRL, the FTA, the test was positive, and then whether there is an increase, fourfold increase in the child. So every torch infection would have a different connotation as far as just what the problem arises when people look at only the life cell report, and because that's the stem cell, they get it, and then there it says IgG positive, IgM positive, and then the child is clinically well and CMV positive, IgM. So we probably need to look at in clinical context and look at specific tests for specific torch infections rather than one general value.
Thank you, Dr. Sanjay. I would totally agree with you. Torches is the misnomer, and you have to deal with each intrauterine infection separately, and many of them, serology has no role. So probably, you look better at your baby's history and his blood test than I think mother's torches. The next question is, many babies
And your voice is no. Pankaj?
We seems to have lost Dr. Neelam's connection. So I read out the question. See, many babies having inborn error metabolism also have delayed cry at birth. So how to differentiate at the earliest stage whether baby has other pathology? So
Sorry, please go ahead.
how do you differentiate
yeah.
that it is not just HIE or HIE with metabolic disorders,
Right.
IEM?
So, ma'am, as we just discussed, like, looking at the history is an important part of like looking at delayed cry. As I said, encephalopathy can be present in anyone. Now, these are general guidelines that we say, okay, जब हम feed शुरू करेंगे, when we start feeds, then we probably would see the manifestation of IEM, but that's not entirely true. Some babies with, like, for example, multiple sulfidase oxidase deficiency would present very early, like, molybdenum co-factor deficiency may present similar to HIE in clinical features, and may be purely metabolic. Some fatty acid oxidation defects may be antenatal, and especially may present with, like, seizures which started in the antenatal period. So these are broad guidelines. But having said that, HIE, if there is a sentinel event, the child was doing fine, and suddenly you have a cord prolapse, and now have a child with an HIE, you will think more in terms of HIE. Now, after that, you would need, like, if you have still a doubt, you would probably need to look at, other manifestation, neuroimaging, and diagnostic tests. For example, as I said, in a child who probably has a fatty acid oxidation defect, unlikely that he will have a basal ganglia and a thalamic and a plic lesion. And a child who probably has, like, multiple oxidase deficiency, say for example, or molybdenum cofactor deficiency, would have myriad of manifestations spread across the center. So you cannot have one single thing, but generally, as a rule, IEM is present later, HA is present early, but it is not a must kind of a rule.
So in other words, your baby could have a hypoxic ischemic event during the intrapartum or peripartum period, and later on would turn out to be a IEM. So basically, you have to manage the both of them. And on the similar lines is the next question also. If baby cried after birth and has features of HIE, then how you diagnose HIE in these kids?
So, that was the layman definition. So, NNF, when started first time, it started with, like, the child who did not cry after birth at 1 minute was called a birth asphyxia. So, all that time, as I said, we started blaming the obstetrician for all delayed cries, and vice versa. So, what we understand that many of these pathologies may be antenatal, and many of these may not be even directly responsible for the intrapartum event. So, say for example, if somebody has a thrombosis in the placenta, would have a decreased blood supply right at the beginning. So, crying at birth is not equivalent to, like, HIE. So some babies with HIE may cry at birth, completely be normal for, you may say, okay, मैं तो उनको घर भेज दिया था, मैंने mother के पास I transferred the child to the mother, and once the child came back, like, with seizures at 12 hours, and then see he's been progressively worsening, or 6 hours. On the contrary, there may be some children who may have, like, hyper alert and had such a thing, and would improve in the next 6 to 8 hours or 12 hours, and we say, okay, this is a child who thought as a HIE, but thankfully does not have manifestation, at best was an HIE. So HIE has to be seen not in terms of not crying at birth, but has to be seen in context of how the neurological symptoms are over a period of time, and what is the progression of the disease, rather than just crying.
Very well said, Dr. Sanjay. So Dr. Manoj, not just look at the cry at birth, but look at other markers, and don't discharge these babies. With any suspicion, don't discharge these babies very early, or at least keep a tag on them. Any role of CSF, routine microscopy, or culture sensitivity if sepsis is suggested? Of course, sure. If sepsis is suspected, you should do the CSF and do the culture as well as the cytology. Sir, please share your experience using sodium valproate in refractory neonatal seizures.
Well, I do not have any, ma'am.
For a long time, I have not used sodium valproate. It's not very safe in newborn, and there are other much safer drugs, anticonvulsants. So probably you can switch to them. How do you treat seizures appearing on EEG but not clinically? If 24 hour, the next is also similar. Is 24 hours EEG available? Yes, you can do 24 hours EEG. And if you have electrical seizures, then probably you have to control them. How to oromotor stimulation in HIE? What is the benefit of tummy time?
So as far as the tummy time is concerned, it increases the tone of the, because we're talking of a hypotonic baby. So when you put the baby onto the back and put it on a pillow, something under a supervision, the child tries to put the head slightly upwards. So that improves the extensor tone of the child. And then oromotor stimulation. So generally we look at, like, putting the rooting reflex. Some people use a finger brush which is small and to help, and some of the occupational therapists even use like a vibrating toothbrush to help, like, stimulate to get the sensations. So the whole idea is that the child, the extrusion reflex, or the ones which is causing his mouth not to like function as a swallowing wave, that thing gets improved, and that whole helps both the feeding and later on the speech as well.
So there are two questions which are interrelated. In place where facilities for body cooling is not there, not using warmers, keeping baby on room temperature will help. I think one of the point which very well Dr. Sanjay covered was that prevent hyperthermia. So probably in these babies, with the temperatures outside very high, whether you are transporting from the labor room or OT to the NICU or from somewhere outside, you have to make sure that these babies don't get hyperthermic. And also, what is your experience with the Mira Cradle? We've been using Mira Cradle. We don't have many babies with hypothermia for the simple reason that, you have to start cooling within first 6 hours. And not many baby who are intramural develop HIE, so, you can't use it. But I think Mira Cradle is fine as long as your selection criteria is fine. You have 1-to-1 nurse ratio, because it's not just putting the baby on hypothermia, on therapeutic hypothermia, but also nursing in these babies is very, very important. Over to you, Dr. Sanjay, your experience with Mira Cradle.
I completely agree with that, ma'am. Like, so one is that, like, the problem with covering hypothermia is that people think that there's a panacea for everything, and like, and if we start hypothermia, suddenly that child would be magically. We need to understand that, like, if you give hypothermia to 7 babies or 6 babies, only one is going to be benefited. So the benefit is not, extremely is 100%. But at the same time, like, when you use a hypothermia, the first thing that you need to see when you look at taking up any new skill, first where you can go wrong. Like, for example, if you do a prolonged hypothermia, you probably will likely to cause PPH, and you may cause coagulation abnormalities, bleeding, another thing. So just make sure that you have the requisite amount of expertise in managing all of the things, and then go to hypothermia. That's my first take on this. And second part is that you rightly said, and that's an NNF guidelines, that if you're using a low cost device, then 1:1 nursing has to be must. If you can't provide it, don't start it. Like, you'll probably cause more harm than benefit in such cases.
Yeah, very rightly said. I think unless until you have good nursing support, you have good ventilation facilities, you have round the clock expert neonatologist or a trained doctor available, you should not think that, therapeutic hypothermia is really going to help you. And probably that's the reason that the large community study, which was done from India, probably put therapeutic hypothermia into the bad repute, because probably the selection of patient, the monitoring, and probably the nursing and the doctor ratio were not appropriate. And that is why there is a word of caution. So anything else, Sanjay, or anybody else? I think I have covered all the questions. I'll again once look at the chat box. Manoj, Pankaj, we have few minutes.
I think, yeah, we have some time, and there's a lot of questions on seizure management. As
Okay,
we
yes.
that which anticonvulsant will be your first line of drug, second line, third
I
line,
think
how long
Dr.
continue to taper?
Yeah. So, Dr. Sanjay, I think you showed one algorithm on first line, second line, and the newer anticonvulsants. But I think one of the questions which most of the people ask is that whether we should continue anticonvulsants after discharge also. So, Sanjay, would you like to
Yes, ma'am. Like,
pick up that
very,
question?
very interesting question, because we have come a long way in neonatology from when we were treating, and we were used to say once a seizure, चाहे वो किसी भी it will happen due to whatever reason, we will continue, anticonvulsant for 3 months by default. Now, from that 3 months, it has gone down to 72 hours of seizure free, especially if it is like an acute provoked seizure. Like, for example, it was due to, an HI, for example, non-refractory, I'm saying, non-refractory, one seizure or two seizures, an acute brain injury, intracranial hemorrhage, whatever there. So you tend to stop at 72 hours, or certainly before discharge to home, because there was one prospective multicentric study on around, if I remember correctly, 300 babies with neonatal seizure who were assigned because of acute provoked seizure. And this was at 24 months. They found that there was no difference in the acute seizure management or medicine continuation and discontinuation within 72 hours. So now we understand, because it's a toxic drug, we know phenobarbital has a potential for a psychomotor retardation, and unless there are manifestations, like, for example, if you have a cerebral malformation, I know there is 100% risk of developing or recurrent seizure, or this is going to continue. But if you have one single episode because of something, and then you are fine neurologically, I would discontinue the medicine. But if you have come and the child is still on anticonvulsants when it comes to your OPD, at that point of time, make sure that you do a complete neurological examination. If you find that the child's neurological examination is fine, much better than what was mentioned in the summary, he is sucking well, maybe you can discontinue without doing a EEG. But if you have a doubt, then and the child is still on anticonvulsant, then maybe getting a continuous EEG at that time. And if it is normal, the neurological examination, you can be safely sure that the child will not have like seizures. There is a 25% risk of any seizure anytime. So, I mean, not taking it into account, but we will prevent many children from having an extended, seizure medicine.
Right. So if it's a single seizure, or what we call as the evoked seizure, then generally the anticonvulsants get discontinued while the course in the NICU. But if a baby has repeated seizures, and especially if he has an abnormal neurological examination, abnormal imaging, and you've done an EEG and the EEG is also abnormal, then it is probably safer to send the baby on maintenance dose and follow the baby in the clinic or in the OPD, do the neurological examination, start early stimulation, and then you can gauge when to stop the anticonvulsants based on the neurological examination, based on the EEG, and based on the recurrence of Caesar. Many a time, by the time you see the baby next, the anticonvulsant medicine is in the homeopathic dose. When you look at the baby's weight, it is really, very, very minuscule. And probably, if your EEG is also normal and baby is doing well, probably it is safer to discontinue the anticonvulsant. And if in doubt, always you can contact the expert. And that could be a neurologist or a neonatal neurologist. I think eventually we are going to have, even in neonatologist also, that he's a neonatal neurologist and he's a neonatal endocrinologist and he's a something else, a neonatal follow-up person. Yes. Yes.
On a very lighter note, once, like, a couple of years back, we had a patient who had some inguinal, swelling, and nobody knew what it was. So he wrote a note that, like, thanks to his swelling, which was noticed by my grandmother, by, like, I found out there are many ists in medicine. I thought it was only one doctor, and, like, I went from endocrinologist to a nephrologist to a urologist, and I do not know if I have a problem of common cold eventually, whether I need to go to a left nephrologist or a right nephrologist.
Right. So, Dr. Pankaj,
Yeah, I think we
there
had a
was,
very
there are some raised hands. So there was some nice name, Aishwarya Abdullah. She
I
raised
just
her hands many a
so
times.
I just see whether I'll allow her to speak.
Right. Two participants
So
now
now
raised hands.
she is allowed to speak. So Aishwarya, you can speak now.
Good morning, respected faculty members.
Yeah, please go
We
ahead.
have three brief questions left. First is, if we suspect sepsis in case of HIE or any encephalopathy, can we send blood culture sensitivity as well?
So Wazir, if you are suspecting sepsis, there's no harm doing a workup. That's what he's asking.
For sure, like in Indian scenario, you can never be sure that this is not
Absolutely.
sepsis. Like, so invariably, if there is an outbound baby, you will end up like, because the CRP is not going to help, the counts are not going to help you in that scenario. And if you've
Yes.
like, child who's probably prolonged labor, PV examinations done outside, you may err on the side of treatment and then tailor according to this.
Yes, sir. Sir, my second question is, which anticonvulsant to taper and withdraw first? First in, first out, or last in, first out?
So if you're doing last in first out, because the first one would be like invariably the phenobarbital, so you would probably keep it and that reserve, and that is the treatment that you need to still continue with when you are discharging the baby, in case you want to continue anticonvulsants even after discharge. So
So, sir,
last in first out.
last in, first out. Yes, sir.
So,
Sir, is there
so the
any rule?
last
Yes,
anticonvulsant on which the seizures were controlled, right?
yes, ma'am.
And also on the dose at which the seizure were controlled, right?
Correct, ma'am.
And then to be followed up. And that's what Sanjay is said.
Yeah, it's fine. Handy.
That will be tapered and removed first.
No, the
The
first
last one.
one, the last one. The last one you will send the baby on. So, like, as Dr. Sanjay said, so if you started phenobarbital and then you later on added levetiracetam, the
Yes, ma'am.
sequence control on levetiracetam, you will discontinue phenobarb while the baby is still in the NICU and maybe send the baby home on maintenance dose of levetiracetam, which could
But
be
ma'am, I don't want to contradict anyone, but the textbooks say that all the anticonvulsants have to be tapered except on phenobarbital.
No, they don't say that. They don't say that.
I think
Ideally, all the anticonvulsants can be weaned unless until you have reasons to continue anticonvulsant, like abnormal EEG, abnormal examination, abnormal imaging. Dr. Pankaj, you wanted to say something?
I think what Dr. Aishwarya is saying is a renewed interest in phenobarb, which now neurologists are trying to say. There's always a difference of opinion between a neurologist and a neonatologist.
Right.
Here, phenobarb is making the baby sedated, and they are not feeling very well because of high phenobarb level. But somehow the trials which have been done, whether it is a comparative between phenobarb and levetiracetam, they are going in favor of phenobarbital in better seizure control. Overall follow-up. So neurological book still right. You continue phenobarbital, you can taper off others first, and that's what Sanjay is also saying. But I also agree with Dr. Neelam. This is a area which is still under evolution, and there's a difference of opinion which you can very well see between what Dr. Neelam is saying and Dr. Sanjay is saying. So this is still area of debate which will keep on improving over a period of time.
Yeah,
Sir,
the
is there any
controversy.
rule of broad spectrum anticonvulsants like topiramate or lamotrigine in neonates?
So I think like these are the second line drugs, and as of now we do not have evidence to suggest that like lamotrigine or anything are good for routine care. Now there are some studies which are basically preclinical animal studies which suggest that topiramate may be neuroprotective in HIE, but at the same time, as of now we do not have an established role. So I would want you to go with one thing, that if you need a seizure control, use phenobarbital, and as madam said, you could probably like levetiracetam or phenobarbital, anyone you can continue, but you must certainly discontinue all this fancy looking like midazolam infusion, lidocaine, and like valproate before discharge, because those are more toxic. So choice could be between phenobarbital and levetiracetam, which is there for, because there is no evidence to suggest that which one is better for a control after discharge. We have evidence to suggest it is good for control of seizures. Phenobarbital is better than levetiracetam for the initiation of treatment, but for discharge we do not have a data.
Sir, my last question is this. Since I'm working in a government hospital, is therapeutic hypothermia available in any government hospital? If yes, please tell where I could refer my patients.
I think Pankaj would be in a better. I think Chacha Nehru has it, no?
Even Kalavati has it now.
Kalavati and Chachanadu. Yes, sir. Thank you
See,
so
my
much, sir.
question.
Thank you so much.
Yeah,
Yes.
thank you so much, Aishwarya. And I think we have only couple of minutes. So, Sanjay, last comment. In this era of medical legal issues, if somebody who's practicing in NCR or a area where the therapeutic cooling is available within a reasonable distance, within say half an hour, 1 hour, so that will be a problem in future if a candidate which is eligible for therapeutic hypothermia is kept by a pediatrician or not being referred to a center which is nearby for therapeutic hypothermia.
I mentioned this during the talk, Pankaj, that if you have a facility available anywhere, even if it is Los Angeles, if I do not explain to the patient that this is a facility available, this amounts to denial of care, which is a medical legal problem. So I can say, okay, he can come. I cannot go to Los Angeles for a treatment of like say hypothermia. That is not my problem. That is like my I need to be considerate, but at the same time, if I deny that kind of a thing, he would say, I was not even aware of this thing. That is a medical legal problem. Now, if having said that, so many centers in Delhi NCR have hypothermia available. So if you do not talk to the patient and get his consent against moving to a facility where therapeutic hypothermia is available, he can sue you in court anytime in future without, so you can rest assured.
So that is very,
Thank you
very
so much.
important point,
So,
Doctor. All the delegates, I think a lot of people who are still residents, they are working in government sector or they are working in very private, smaller centers. So you must be aware that therapeutic hypothermia is standard of care today in management of hypoxic ischemic encephalopathy. There are very standard guidelines from National Neonatology Forum and which babies are eligible, which centers are eligible. One should be aware of the centers nearby and you should be able to transport them or take help of these centers in getting the babies transported to them in time so that whatever is possible in the management of these babies can be offered to them. So with these comments I will be coming at the end of today's session. It was a very, very nice session and the maximum people who are attending were close to 300, and I'm sure many more people will be attending once we make it live, which will be doing it after 24 hours. I'll thank Dr. Neelam Clare, Professor Neelam Clare, for beautifully chairing the session and taking all the questions and also putting her inputs into the issues. I definitely thank Dr. Sanjay Wazir, my good friend, and always a very great orator and very good slides which he presented on such a difficult topic, neonatal encephalopathy. Thank you, Dr. Sanjay. And last but not the least, Dr. Alok, who is still on the platform. It is Dr. Alok Bhandari's vision to make multiple e-courses in his tenure of Delhi IPA president. We already have done dermatology and we have done endocrinology and we have done hematology and now we are doing neonatology. So it is good that we keep on doing some academic activity on Delhi IAP platform. And I thank Sushil, who's been working since morning on this platform to make the smooth presentation. And he also will be responsible for recording it and sharing with all of you. With these words, thank you so much and have a nice Sunday. Enjoy your Sunday now in more non-academic events than academic. Thank you so much. Bye-bye.
Thank you,
Thank you, sir.
Thank you, Neelam.
Thank you so much.